All right, welcome everyone to our week 10 session for our Project ECHO. This is the introduction to palliative care in humanitarian settings, and we're really glad that you're with us today. I hope everyone who wanted a break got a break last week, and for those that are celebrating Eid this coming weekend, we hope that you have a nice weekend coming up as well. This week, we will be talking about end-of-life care, which is a really important aspect of palliative care. And we will also be discussing some practical nursing issues related to palliative care and how you can support your patients and families at home or in the hospital or wherever you see your patients in outpatient clinics as well. So I'll introduce Dr. Hunter Groinger. He's our one of our faculty members. I think most of you have met him previously. He will be taking us through the end-of-life part of the program. He works in the US and has been supporting the Project ECHO training for several years now in Kenya, East Africa, and Bangladesh, which is great. And then I'll be doing the nursing talk later on, and then we'll do the case study as well. And we'll allow for lots of time of discussion. And of course, if you have any questions, put them in the chat. If you can remain muted, like always, until we open the discussion time up. And if you're able to put your video on, that's great too. Thanks a lot, and over to you, Dr. Hunter.
Hello, everyone. Can everyone hear me? Okay. Can you hear me? I see some nods.
Yeah.
Good. Great. Okay. I am going to share my screen, and then we'll get started. Let's see if I can do this right. Okay, can you see slides?
Yep,
Yeah,
that's good.
Great. Okay. Okay, here we go. Good morning for folks who are in North America, and good afternoon for folks who are over in Africa. I am a palliative medicine physician, and I'm going to spend a few minutes talking this morning about what we commonly refer to as the last hours of life, or end-of-life care. And when I say the last hours of life, that could be a couple of hours, 2 or 3, it could be a few days, but a very short time frame in which some important things tend to happen with our patients physiologically that demand our attention and awareness, and also important experiences that can happen to the patient's loved ones or family members or caregivers who are providing care for our patients. So I hope that after we talk a little bit this morning, that you'll be able to describe common physical findings that are associated with the last hours of life, or what some people call the syndrome of imminent death. I'll talk about that in a moment. Name some common symptoms that are associated with the dying process and how we can be aware of those and anticipate them. And then to describe the role of multidisciplinary palliative care, supporting the family, supporting the loved ones and caregivers at end of life. So let's start with a case to illustrate some of these principles. Imagine this 56-year-old woman who has metastatic breast cancer and is no longer receiving any anti-cancer therapies. She lives with her family, who consists of a husband and a brother and 3 children. And when you encounter the family, they describe her declining physical function and her activities in recent weeks. She's become more bedbound. She has very little food intake or water intake. And occasionally she seems to be hallucinating or moaning. So I think in the context of what we've been talking about for the last 9 or 10 weeks, here's an opportunity for us to think a little bit about what are some potential sources of suffering that are happening right here. So I would like to orient your thinking in this case to conceptualizing what is going on in this scenario. What are important pieces of information that we can tell the patient if the patient can interact with us and the family who's there? What symptoms should we be on the lookout for? And how can we leverage our entire palliative care team to assist in this very important life experience? So keep that in mind for the rest of this talk. So I'm going to talk a little bit about what is written about in clinical literature as the syndrome of imminent death, which is just what it sounds like. And we often will kind of colloquially refer to this as just the last hours of life. And this really is a common pathway across many illnesses of common physiologic experiences that the body goes through as it approaches death. And many people describe different stages of this: an early stage where a patient might be more bedbound, have less food or water intake, and may have more cognitive changes. Maybe the patient is sleeping more. Maybe there is some delirium, a delirium that could be hyperactive with a little bit of agitation. Think of the patients that are getting confused, trying to get out of bed, even though it's not safe to do that. Or a hypoactive delirium, just not very aware, not very engaged, not really making sense when they're trying to communicate. And there can be kind of a middle stage where this early stage kind of expands and the mental status continues to decline. And then a very late stage, which is really marked by the phenomena of the body shutting down. So what we often loosely refer to as a death rattle, which is really just excessive secretions that are pooled in the oropharynx. The patient may slip into a coma, a comatose state, and not engaging at all. Very common for patients at this stage to experience a fever, altered respiratory patterns, such as breathing very minimally, or may have very rapid, shallow breathing periods, or what we commonly see are called Cheyne-Stokes respiratory patterns, where the patient will have very deep breaths for a while and then just stop breathing, long periods of apnea. I've sometimes counted 30 seconds, 40 seconds of apnea before the breathing starts again. And this is extremely common in the very final stages of life. And finally, mottled extremities, where the hands and feet become cool to the touch, might have some skin changes associated with decreased perfusion of the skin. So this is a syndrome. It's a collection of physiologic phenomena and experiences that can happen sort of in varying degrees depending on the individual, but a common syndrome. And there's as I mentioned before, sort of a time course that kind of can generally give us a sense about where this person might be on that very end of life trajectory. And sometimes I think we can, especially with a lot of experience practicing palliative care, I think that we can begin to get better and better at estimating how much time someone really has, how close they are to death, based on some of the progression of these particular symptoms. So across this range, we might think of someone who is extremely cachectic, who's been living with a progressive illness like breast cancer and has had a notable progressive functional decline, that the syndrome of imminent death really can herald death coming within some number of hours. And on this spectrum, you could say maybe less than 24 hours. Sometimes when we talk about prognosticating, we might say hours to a couple of days. but not much beyond that. Someone who is approaching end of life, who before an event that led them to end of life was well nourished, maybe experienced a traumatic injury or an acute illness, like a pneumonia that can't be cured. That person has more physiologic reserve, and this dying process, this syndrome of imminent death, may take longer. So I would invite you to sort of think about this spectrum and think about the case that I shared with you, and maybe reflect where our patient might be on the spectrum. And I think, based on the fact that she has a progressive illness, she has metastatic breast cancer, and there's a story that the family is able to tell of progressive functional decline, as well as some signs that we can see when we see her, like she's not eating and drinking, she's cachectic, she's lost weight. She probably has some number of hours to live, and that could be 2 hours, it could be 48 hours, but probably not much beyond that based on what we're seeing. And I think that our role as palliative care experts really not only includes the assessment of the patient's physical symptoms and addressing those symptoms, addressing that physical and emotional suffering of a patient, but also addressing family concerns. And these are some common questions that come up from family members, especially those who have not experienced this before or experienced this before in the home setting. And so you can take a look at some of these questions. Is our loved one in pain? How do we know if she's in pain? What do we do if we think she's in pain? Should I stay at the bedside? What happens after she dies? We're going to talk about some sort of approaches to these common questions in a moment. So we've talked about I've described the syndrome of imminent death, or kind of the common pathway of the last hours of life. And I want to talk now a little bit about how we, now that we can recognize that, how we can begin to address it. And I want to go back to the questions that I had just brought up a minute ago that are very common questions from loved ones who are providing care in the home setting. I really always encourage people, as you do this work, to learn different strategies of communicating the answers that are appropriate to these questions, these concerns, and helping families to navigate this process. That's a huge part of our job. I often find that as one does this work more and more, that you will find the language that works, that sort of suits you the best, that fits the situation the best, that you're most comfortable using. But I thought I would share just some ideas about how I might approach these questions from family members in this setting, just so you could start to kind of think a little bit about what might work for you when you're in this situation. So the question is our loved one in pain? How do we know? Well, part of our job as palliative care experts is to be able to assess pain, both in people who can communicate with us and people who cannot, like this patient. And we've talked in earlier sessions about pain assessment and pain management. I think in the family setting, it's very important to reassure the family that that is a very important part of our job, and we will work very, very hard to prevent physical discomfort, and if it arises, to address it. Families need to know that we have the skills to do that, and we will work very hard to make sure that the patient is comfortable. It's very common for families to wonder whether their loved one is starving to death, because of course, as the patient enters the dying phase, they're not able to eat and drink. And it's very important that we're able to reassure them that no, this patient is not starving. Not eating, not drinking is a normal part of the body shutting down. It's a normal process. And to the best of our ability to know at the bedside and through whatever clinical studies and education that we know, there are no signals from patients who are in the last hours of life that their body is hungry, that they're wanting to be able to eat and wanting to be able to drink. And sometimes I share with families that forcing nutrition or forcing hydration could very well likely lead to more physical discomfort. When the families ask, what should we expect? How will we know that time is very short? That's part of our job to help kind of assess and reassess along that spectrum that I shared with you earlier, and to help people be able to prepare for what might be coming in the next hours or days. I often feel like part of our palliative care skill set is to be able to see a little bit into the future to the best of our ability and help families anticipate what might happen later tonight or tomorrow between now and the next time that you go to visit them. Should we stay by the bedside? Sometimes it's really important to family members to be present at the bedside. For some individuals or some families, being present at the moment of death is very important to them and very important to that family experience. And so we can say, if that's really important that someone is there at the bedside, then yes, you should probably stay there or take turns staying there so someone is always present, because we never really know when that moment will come, the final moment of life. It is also really important to remind people, just for reasons of patient care and safety, that that the patient should never be left alone in the home. People don't have to stay in the room at the bedside every moment of the day, but should not be leaving the patient alone in the home because the patient is not able to advocate for himself or herself. Can our loved one hear what we are saying? I often say it is impossible to know for sure, but sometimes we believe that hearing is one of the last sensations to go. And sometimes our patients signal to us that they can hear and understand what's happening around them. So I always speak at the bedside as if I know the patient is able to hear me. And I always recommend to families, if you want to talk to your loved one, go ahead and do that. Tell them what you want to tell them. Tell them that they're safe. Tell them that we'll continue to take care of them, and feel free to do that. And then what do we do after death? Certainly, I definitely can speak to American culture that unfortunately death is often seen as an emergency, but it's not in this situation. Death is a planned event that we know is coming, and we're anticipating end of life happening sometime in the coming hours or days. And part of our job as a palliative care team is to make a plan with the family about what to do after the patient dies, who the family needs to call, and what needs to happen next to support the family and to support whatever burial processes or end of life or post-death care needs to happen. So again, these are just some answers that I've sort of cultivated myself in my own practice. You should think about these and modify them the way that works for you. And sometimes the answers vary depending on the family and the situation, but just to give kind of a general sense about some common concerns I think might be helpful. So the last thing I wanted to really emphasize is the multidisciplinary nature of the work that we do. How can we involve the entire palliative care team in this extremely important life experience? So please always go back to kind of our core roots in this field, that we're a multidisciplinary, interdisciplinary field. That when we work with patients, when we work with families, that we are all the time assessing these four modalities of life experience and potentially of suffering. And we've talked a little bit about, for this case, in the scenario, we've talked a little bit about physical symptoms and sources of physical suffering. We've talked a little bit about psychological distress, particularly related to how this can be distressing to the family and how we can support them and reassure them and educate them. It's also important as palliative care providers that we are assessing the patient's spiritual life and any spiritual distress. Same goes for the family, and using our own caregiving tools and our spiritual care expert colleagues to help assure that patients and families are supported at this critical moment. And then finally, end-of-life care can be incredibly distressing from a societal standpoint or a social standpoint to the family unit. This moment when this particular patient dies will signal a breakdown of the family unit as it was before. This is a mother and a wife and a sister. And when she is gone, those relationships will change. For many families that we provide care for, the death of a patient can lead to important social and financial implications to the family unit afterwards. And that should be part of our holistic assessment to understand that and, to the best of our abilities, support those transitions. And then I wanted to talk a little bit about just some common themes and approaches around management of end-of-life care, to give people, again, just like the beginnings of how you might approach this common scenario. First, always, this is an opportunity to confirm overall treatment goals and then adjust any treatment plans as necessary. So in going back to our case, this is a really important opportunity to look at medications that the patient may have been prescribed and to stop medications that are not relevant to comfort, because medications that are not relevant to comfort are not going to be helpful at this time. And here's a phrase that I often use with family members to support them and reassure them that we're not so much taking something away from the patient as really focusing our efforts the best to promote that goal of comfort. And so I might say something at the bedside like, we want to really do everything we can that promotes our goal of comfort. And we want to stop interventions, stop medications or other treatment processes that are not helping that goal. And I think that sometimes that helps families feel reassured that we're continuing to be very proactive, just realizing that the situation and our goal is shifting as the patient approaches death. It's really important to communicate clearly what's going on. There are different ways to do that, and you'll find the way that is most comfortable to you and which will fit with the families that you're working with. But it's important to be really clear. You might need to say, the patient is actively dying, or your loved one will not live much longer. I know that in Western cultures, we often use euphemisms like the patient is transitioning, or the patient may be passing, and that sometimes I find language like that that is softer and not as clear can be very confusing to families. So I think it's important, again, using our best palliative communication skills to be clear about what's happening, but in a supportive way. It's always important to provide excellent mouth and skin care. And for many family members that really need to feel like they're doing something to provide care, this is a great intervention that they can do. That they can be active at the bedside if they want to. They can use mouth swabs, help to keep the lips moist or just the inside of the mouth moist. That can be very comfortable for patients, and it can help family members feel like they're participating in care rather than having to be sort of passive in a way. And then I think, as I've tried to reinforce, our role really involves a lot of frequent counseling and support to families as the process changes hour to hour or day to day, and being aware and anticipating symptoms as they arise. And so in summary, I often teach my trainees that during the last days of life, there are some very common symptoms to be on the lookout for. It doesn't mean that every patient has all of these symptoms at any given time, or they may have some and then these symptoms shift over the hours to days approaching death. But these are the most common symptoms that the body can go through at the end of life. So I really think it's important to be on the lookout for them and have a plan that you're ready to address proactively. So pain, shortness of breath, nausea, constipation particularly sometimes related to the opioid therapies that we're using to manage pain or dyspnea, and because these patients are relatively immobile. And even if they're not eating and drinking, it is should be expected that every number of days that they should be able to pass a bowel movement. So being on the lookout for constipation. We've talked a little bit about sort of a hyperactive delirium or agitation that can be very distressing to families and sometimes very challenging to manage at home. Anxiety, excessive oral secretions, and as I mentioned before, a fever. So I think it's helpful to have this list in your mind when you are providing care for patients at end of life and be on the lookout and be thinking proactively about what might be coming around the corner, what medications do I want to have available, how can I proactively educate and reassure the family how to be on the lookout for these symptoms when the palliative care team is not in the home, and at least start to administer therapies to mitigate symptoms. So in summary, I hope that this was a helpful introduction to recognize the syndrome of imminent death, to talk through different strategies for communication and support to families, and then recognizing, planning, and communicating about common symptoms in the last hours of life. I find this particular part of palliative care to be extremely rewarding. This is such an important moment in the life of the patient, in the life of the family unit, and I find it very rewarding to be able to be present at this time, and I hope you do too. I will stop there. Thank you so much for your attention.
Thanks, Dr. Hunter. So, yeah, I'm really interested to hear what people's thoughts are, or initial thoughts on this topic. We'll spend about 5 minutes or so just talking about any questions that you may have or something that you may not agree with Dr. Hunter. Of course, every culture is quite different, and we know that sometimes we practice in a way that may not be the best practice, but it is what's done in our setting. So, yeah, does anyone want to jump in with a question while Dr. Hunter is with us related to end-of-life care? I know for myself, I did a lot of home care in Canada, and I think the comment that you were saying, Dr. Hunter, where you don't really want to say that the person is dying, so we often use words that may seem more peaceful, but can be very confusing. What are other people's thoughts on that? Oh, Dr. Zippy is with us well today. Welcome, Dr. Zippy. What do you guys say when you clearly know a patient is dying to your family? And what maybe have you learned today that you could try to maybe next time maybe change? Yeah, Tabello?
I think Dr. Hunter is very much correct when he says we should be clear about what we mean so that it doesn't create any confusion for the families. However, I think having been aware of different cultures and how death is being perceived, I certainly see that here in UK, where I'm practicing at the moment, it is very much acceptable to become as clear as possible with the right words without really mimicking any understanding about death and dying. So just to become clear, it is quite acceptable and appropriate. But at the same time, when you see other cultures in the African content whereby death and dying are still treated as taboo, you tend to
Sorry.
Yeah, you tend to end up
Right, everyone, just remember to remain muted unless you're sharing. Sorry, Tabello.
Yeah, all right. Thank you. You tend to actually use the culturally appropriate words. However, I believe with the communication skills and training that we have all been exposed to, I believe everyone that has been able to have an exposure to this kind of training should be able to have some kind of confidence to be able to approach patients and families in a better way that it still leaves them with a clear understanding of where we are heading with the clinical condition of the patient without really leaving them with mixed feelings or false hope of as if they are going to get better. And that's why I really appreciated this kind of training that you have all been arranging for everybody else that have accessed it. And therefore, I'm encouraging my colleagues from Lesotho that now we know how best we can communicate with the families, regardless of the culturally words that you know, they don't want to hear, but then we need to give them information, because if they are not clear that somebody is actually for end of life, that is in a similar situation in Lesotho, whereby you'll find that when somebody starts gasping and have for that dyspnea and they are in severe pain, they hire somebody's van from the neighborhood and pay a lot of money. Sometimes they don't even have that money to pay instantly, and they take the patient to A&E when they should have just made the patient comfortable, give them whatever the painkillers they might have in the house, and just let them rest. And you'll find that they die on the way, or just after being put in the van on a little thin mattress. That's when they die, or they die at A&E. Just because the words were not very clear when they were last seen at the hospital or when they were discharged, that this is the end of the journey. We just need to keep the patient comfortable, or approach the local clinic for more painkillers. But this is the state of the situation. So thank you very much for all the trainings we are getting. Yeah.
Thank you, Tabelo. It's really helpful to hear your perspective, and I know you have several of your colleagues on the line, so thanks so much for sharing. Dr. Hunter, there's a few things that have come up on the chat that I thought we could address. Do you resuscitate a palliative care patient who's in the process of dying?
What was the question? Do you resuscitate a palliative care patient who's in the process of dying? That's a really great question. I think that, well, the first thing I will say, just in response to Tabella, that was a great comment. Thank you, about cultural awareness and being mindful of sort of the culture where you're practicing, the family unit, and how they work as a unit, and how our best communication skills really need to sort of fit the situation at hand. And I think what I'm hoping to advocate for is just that when patients and families are seeking information, that we're able to comfortably communicate in a supportive, kind way the information that they need to hear. But of course, it has to be done in a way that aligns with the local culture, the family culture, and so on. And that's our palliative skill set, is to really know how to communicate best and what to communicate and when. So thank you you said it better than I did. I really appreciate that. The question, do we resuscitate palliative care patients who are in the process of dying? Well, I think that really goes back to a comment that I was making about confirming goals of care, confirming what kind of care the patient is appropriate to the patient at this time in life, what feels appropriate to the family. And I think that part of that also involves, again, the supportive, skillful, palliative communication about what is happening medically at this time. Normally, in my experience, when patients are approaching end of life, they understand that, and the family understands that, and the patient and family's goal is for the patient to be comfortable and to die comfortably. Then typically trying to resuscitate that patient does not really line up with that goal of allowing a comfortable death. And so it is typically something that we would not encourage because for medical reasons, it probably won't work. And most importantly, if that's not in line with the patient's goal or the family unit's goal, then that's something that will not be helpful to do. That's a tricky situation. It's something that I know happens in my clinical practice a lot, those questions. And I think that's part of our palliative skill set, is to help patients and families navigate through that. That's a big, broad, generic answer, but these are very specific cases that happen on a patient-by-patient case.
Yeah, and I think the thing is probably some of the questioning or the reasoning behind that question is maybe families asked for their loved ones to be resuscitated, and it was very difficult to know in the moment what to say. But There's a few other comments, and I know Mary Claire has her hand up. So in Uganda, there's a few participants have shared that you're not allowed to tell a family that the patient is dying. How do we deal with that? Even if Dr. Zippy is still on the line with us. Dr. Zippy has been working in East Africa for many years, and she is Kenyan. Dr. Zippy, do you feel like answering that question, or should we give it to Dr. Hunter? She might not be able to unmute. Okay, Dr. Hunter, what do you think? When our culture has such strong values of not telling people that someone is very sick and dying, how can we approach that?
Well, I can't speak for all cultures and the best way to approach different cultures. I think my first answer might be it can be helpful, I think, to try to investigate what the patient or what the family understands is happening and get a sense of what are they seeing? What do they believe is happening? What do they expect will happen? What are they worried will happen? What do they hope might happen? That's a lot of questions, but I think asking questions, trying to understand how people are experiencing this and what their knowledge is can be a very helpful way to prompt these conversations that can be difficult to navigate, because then the patient or the family member is really putting their experiences out for you to react to and to be able to help support them through. I have found very, very often when I ask questions to a patient or a family member in these types of situations, not just what do you think is happening, but what are you worried about? And really open up some important content for a supportive conversation, and can open some doors of communication that might not have been there before in a way that is not at all confrontational, but very supportive to people, because you're asking what they're worried about and how you can help. I think that's my first take at that answer.
Yeah.
It's tricky to navigate.
There are, there's another question, but Dr. Hunter, we may move on. I'd love Mary Claire and Esther to comment, but Dr. Hunter, can you answer this one question in the chat, just regarding from Dr. Amable, where patients sometimes seem to get healthy before they die or before they pass away. Is it true? And is this also a sign of imminent death? I think from my experience, it can happen fairly often. So, and I know that you obviously have been working in palliative care for a while. So if you could maybe just put in the chat your thoughts on that question. Mary Claire, do you wanna, I know that you had your hand up.
Yes, thank you very much, Dr. Hunter, for this great presentation. I just wanted to ask you something. You know, as a nurse, I was asked to see a patient, and I wasn't supposed to talk about palliative care. So, you know, I was a support, but no talk about palliative care. When I got to the room, they all told me that the patient is dying, and he is telling them that he doesn't have a lot of time to stay. His time is limited. And he's a young 39 years old guy, and he has 2 children en bas âge, they are small. This was last week. And today I passed by the family. He didn't want to talk a lot, but his daughter told me, his sister told me when the doctor comes to the room, he gives him positive vibes. And when we go out of the room, he tells me that things are not okay. So I was a little bit, maybe I don't know how to react. I tried to tell them, be clear with the patient, tell the doctor to be clear with the patient, because he has a lot of things he has unfinished business. He told me, I have children and I have to I have to know where I'm going. So what is the way to try and pass the message without being as a nurse, you know, I don't have the right. It's a palliative care is still a fight here in Lebanon.
Yeah, thanks.
And
That's a great question. Of course.
And all the family is aware of it, you know, but they want the doctor to help them to understand.
Yeah,
Thank
that's
you.
a great question. It's a complex case, although it's a common case. I think we all see cases like that. And I guess the brief answer that I'll give now, because I know we need to move on to the next topic, is I always think that those are great opportunities to ask questions, ask the patient, ask the family. Again, what do you think is happening? What do you think about what the other doctor's saying? What are you worried about? Because it starts to bring that content into the room. They're bringing it into the room. So you're not telling them you're dying and this is what I'm saying and this is what I'm seeing. You're bringing out their own experiences. I usually find that a dying patient knows that they're dying. They can just feel it. They're lived in that body their whole lives. And if you can open up a supportive conversation just by asking questions, that can help a conversation to start, and then go from there. That's my quick answer. I know these are great cases and it'd be great to talk more about them sometime. So I'll pass it back to Erin. I know we have a time.
Okay,
crunch.
thank you, doctor.
I know that whenever we learn about communication, even outside of palliative care, answering the question does really help people open up, and it does lead to a good conversation and more clarity. So although it isn't easy, engaging with them in that way may be helpful. Esther, do you have one final thought? And then we're going to move on to the nursing part.
Oh, I was just, along with what Dr. Groinger said, I think that in some cultures where you can't say that the person is dying, you can still say, this is what we see when somebody is getting closer to end of life. We know in some of the cultures that they're going to hope for healing till the end. So we can say we still hope that this person can be healed, but we're worried that if we don't recognize what's happening, you might end up spending money or having a crisis or having the person actually pass away in a vehicle. Not sure, but I also was going to say that I think it's important for us to start talking about death and dying before we're actually at that point. So these are conversations that you can slowly introduce as you get to know your patients.
Mm-hmm. Yeah, I think it's really good that we have this group. So this is the area where we can talk about this. We can gain confidence from one another. Of course, we don't want to be culturally insensitive because then obviously we're building palliative care in the settings where we're working, and we are few people that are that know about ways to support families through this. But yeah, I think it's a really good point. So there's a few questions in the chat. Maybe, I don't know how long you can be online, the other faculty members, but if you mind replying to them, we are going to move on to the nursing issues. Let me just share my screen. So when we think of nursing issues in palliative care, it's quite vast. So of course, the first topic that we were talking about today is really at the end of life. When we think of nursing care in palliative care, it doesn't necessarily mean just at the end of life. When we think about nursing care, we're going to be talking about these 7 topics, and I may not get through all of them today. But I will definitely either record myself sharing this lecture or we can follow up with it next week because we still have one more class. And I'd really like for us to save the last 20 minutes or so for our case presentation. So I'll be covering how to do a bed bath, transferring, skin care, wound care, mouth care, stomach care, and lymphedema care. So as you can tell, a lot of these are just general nursing care, but what often happens is If our patients are being seen as an outpatient or even in the hospital, we may be the most skilled person on the palliative care team to provide the support that these patients need. So when we think about a bed bath, what I mean by bed bath is giving someone a wash that can't leave their bed. So we may have someone who's bed bound, and it's really important that these patients, their hygiene is taken care of. So we want to make sure we do a bed bath or wash them every day or every other day, especially washing your face, hands, and the perineum area every day if the patient doesn't want to be washed fully. And you may need 1 or 2 people to do this. Generally, we suggest to have a small cloth, water, soap, and clean clothes after the bath has occurred. You may need a plastic sheet just in case there is extra water that gets the linens wet. But usually we recommend to do this before you change the bed linens in most of our patients. So then we can move on to transferring. So when we think of these patients that are quite weak, they're not able to do things on their own, we may have identified them as having in need of some support from a caregiver. You want to first explain to the patient what you're doing. So if you're hoping to transfer them from the bed to the chair or their wheelchair back to the bed, you want to let them know what you're doing. You always want to make sure you keep your knees bent as a caregiver or as a healthcare provider. You then fold the arms of the patient and you try to put one of your legs as the person transferring in between the patient's legs. And we do this so that if the patient gets very weak or you're not able to transfer them well, they don't fall directly onto the floor. They would then rest on your knee. You would then grab a hold of the person's trousers or whatever clothing that they're wearing, and you use that to lift the patient. Many of our patients, we know their skin is very weak. So you don't want to be grabbing directly onto their skin. And then you position the patient near the side of the bed and secure the chair. So you don't want to be transferring someone from the middle of the bed or somewhere that's difficult to reach. You then lift the patient up by bending your knees and you shift them into the chair. And just making sure the patient is comfortable and definitely that the brakes are on the wheelchair if you're using a wheelchair. And I can send over a video of this. I did this and we taped it, so I can pass that over as well. In terms of general skincare, we really focus on preventing pressure sores or bed sores by repositioning our patients every 2 hours. So if you have someone that's not able to move on their own, or they're not able to get out of bed or even sit at the side of the bed, it's really important that you teach a caregiver or even a nursing aide or one of the nurses on the unit that they need to be repositioning this person every few hours, or they will for sure get a pressure sore. You want to be aware of the risk areas, and we need to make sure we move patients properly in the bed. Using moisturizing cream and changing linens daily is really helpful, and especially changing them if the patient is incontinent or they're sweating a lot. That's important. If you have access, of course, we know in many of the settings where we're working, we have limited access to resources. The air bed is helpful, and the more official name is a pneumatic bed. So this is what it looks like. It's a cushion bed that has air that ripples through it. And of course, you would need electricity also for that, but it can be really helpful for relieving pressure for patients on their skin. Here's a picture of a patient in Asia, where the caregiver obviously looks very proud in this picture because she's been able to position the patient, who is very thin and looks quite ill, in a way that he's most comfortable. So she's using pillows, some rolled up blankets, making sure the pressure points aren't directly on the area. So there you can see the heels are just off of the pillow. This is one really helpful way to reduce pressure to the bottom of the heel. So when we use draw sheets, you may have a patient who's in the hospital or at bed and they're not able to get up. We sometimes suggest to put an extra sheet, not just the bed sheet, but a draw sheet. So that can help us move a patient up in bed. Obviously, gravity is sometimes against us. So patients can move down lower and lower in the bed, and they can have a lot of pressure on their heels. So you can use this and obviously explain to the patient what you're doing. And then together on the count of 3, you can move the sheet up. And this really does help with pressure points on a patient's heel. These are the areas that we were talking about. So you can review this when you take a look at these notes, but these are the points that you would want to be aware of and making sure there's less pressure on this area. Sometimes we forget about the back of the head and ears, but for our patients that are not moving regularly, it's really important we focus on that as well. So now moving to wound care. If you have a patient who is palliative, we often think of wound care for non-healing wounds. So these are not surgical wounds that have just come out of surgery that are aseptic technique. We often talk about wound care in palliative care as a clean wound care technique. So we want to use normal saline or cooled boiled water, and we use to irrigate the wounds with the syringe. We try not to wipe with gauze. So you might be in the habit of wiping patients' wounds with gauze, but what happens is it actually causes damage to the new tissue. And sometimes even the gauze can shed some of the fibers into the wound, and it does delay the healing. So you want to use a syringe, obviously not with a needle, to irrigate the wound as you're cleaning it. And we really recommend not to use antiseptics. We know that, and research shows that antiseptics are not recommended. Again, I know it's very common for us to use chlorhexidine, iodine, betadine, hydrogen peroxide. These are very common for us to use, but actually what happens is it damages the new skin cells that are trying to heal. It does kill bacteria, which is really important, but it also kills those clean cells. So for these wounds that may not fully heal, we want to prioritize any new skin that is growing, and we don't often worry as much about that bacteria. So using normal saline or teaching a family how to make their own normal saline is really important. And again, I can also add that into our references, a recipe for making normal saline at home. You may find also some of these other wound issues: pain, foul smell, bleeding, and maggots. I'll go through them fairly quickly because we want to be able to go on the case today. But as we manage pain, sometimes it's important to give morphine for our patients that are we're doing these wounds on, especially if the patient is already on morphine. You can give the as needed doses 30 minutes before. Sometimes we also give midazolam for children that have had very traumatic wound experiences, and the recommendations are there. For the foul smell, it is best practice to use metronidazole crushed tablets. So often you can easily get that in your setting. There is some new research out from Asia that says we can also use tea bag in a secondary dressing to absorb or reduce the smell. And again, if you want more information about that, I would be happy to give that to you. We did do using tea bags in Nairobi, and it worked out very well for a patient that had a very foul smelling fungating wound on her breast. But oftentimes these patients will also need frequent dressing changes. If your patient has bleeding to the wound, you would want to use crushed sulcrafate mixed with Vaseline, or possibly even tranexamic acid for bleeding that happens more extreme. And you do want to apply pressure directly on that, or you can even use adrenaline. So these are some things that you would want to have in place to make sure that you can provide the right care to the patient, especially if they have a wound that is at risk for bleeding. In terms of maggots, and we do know that some of our patients have this due to their living situation or even in the hospital with flies on wounds, we really recommend wounds be covered. And that's the best way to prevent these things from happening. We can remove the maggots. It does take a long time. It is very important that you do that. You can either use raw meat directly over the wound. It often will draw the maggots out, or you can use turpentine. You just want to make sure you don't have the turpentine touch the skin. And these dressings may need to be done more often, possibly up to 3 times a day. Now, as we move from skincare, we can talk about mouth care. So mouth care needs to be done, especially for patients that are very end of life, where they can't do their own mouth care, 2 to 3 times a day. We want to make sure we're lubricating a patient's lips because it can be really dry, and we do need to watch out for thrush or candidinitis candidiasis, the white patches in people's nose. And this can often be treated with nystatin. And you can actually swallow the nystatin just in case the infection has gone down their esophagus. Some of our patients in palliative care, because we often also support oncology patients, is stoma care. So it's important that we provide good quality of life as we provide stoma care for patients. So this includes a colostomy as well as a tracheostomy. These are fairly specific nursing skills. And if you would like more information, we'd be happy to give this to you if you have patients that have had surgery and need support on this. There's some really good techniques. Of course, I know supplies are very expensive and it may be very difficult for people to access supplies. But definitely in Kenya, we have some good support. So please reach out if you have patients dealing with this. And lymphedema. So lymphedema is when there is a collection of lymph or fluid in the interstitial space because of a decreased ability for the lymphatic system to drain that area. It often happens for our patients that have had breast surgery or breast cancer surgery. Sometimes it does happen in patients with lower limb implications. So lymphedema is very important. These patients often deal with nerve pain and their quality of life is quite poor. So if you have a patient that has severe swelling in their limbs, please do reach out to one of our consultants here in Nairobi and we can find ways to support you. That's really, really important. So just as we think about lymphedema, the 4 areas that you want to focus on are skincare, compression, massage, and exercise. So skincare obviously can be done by any person. Compression usually needs to be done by someone who is trained in lymphedema care. Exercise can also be trained to the caregiver or the patient. And oftentimes lymphedema massage does need to be taught. So if you are interested, we do have some people that can support you in that here in Kenya. And I think we are nearly finished. So just in summary of the things we talked about today, nursing is really important in palliative care. And you may find that you're a nurse and you're doing many different things to provide support for the family. Some of these things we can teach to caregivers. And then, of course, there are some things that we do need to do with specialized training. But if you have any specific questions about nursing issues, please do reach out. I am a palliative care nurse, and I am really passionate about this type of care that we can provide our patients. I know even in limited resource settings, we can offer good support to our patients. So I will end there. We can maybe take 1 or 2 questions about I haven't been checking the chat, but we can take a few questions about the nursing and then we'll get on to, the case. Okay, I think Dr. Hunter was replying to a few things, which is good. Yes, in terms of antiseptics, oftentimes we use antiseptics because we don't have access to clean water or normal saline. So if you don't have access to clean boiled water or normal saline, of course you should use antiseptic. You would never want to clean a wound with dirty water, but it actually does kill the cells quickly. So I'm happy to share some of those research articles with you. If you don't believe me, that's fine. Sometimes it does take a while to believe a change in technique that we've been using for many, many years, but I can definitely pass that along. Replacements for antiseptics would be normal saline. So you should have access to that in your clinics. We do often know that patients wouldn't be buying normal saline from a pharmacy. It's not very affordable. So we often teach them how to make normal saline at home. That includes using salt and water, clean water, and then you boil that for a certain amount of time and then you keep that in a closed container. So you can use that as well. Yeah, Edna, normal saline is what we use. Okay, and then for the tea bags, yes. So for foul smelling fungating wounds, we actually use tea bags because of the properties in the tea leaves. It absorbs the smell. And it is the same tea that we drink. The research that was done in Asia was using green tea because that's the type of tea that often is used in that area. The research was done in Singapore, but you can also use black tea leaves, those little tea bags that are kind of circular, or the ones with the tags, whatever, a tea bag. And then what you do is you do your normal wound care. You would then apply metronidazole crushed powder on the first layer directly onto the wound, and then you would put a piece of gauze. And then on the second layer, so a second layer of dressing, then you would put the tea bag. So the tea bag does not go directly on the skin. And then you cover that with an outer dressing, and then you tape it or wrap it, however you've been doing it. I'm happy to share the information. I know, again, it sounds a bit different, but it is a very affordable way for people to support someone with foul smelling, fungating wounds. We also recommend charcoal at the bedside in a small bowl. Sometimes you can put that under the side table or underneath the bed, and it also helps to absorb the smell. How long to apply the meat? Okay, so you don't want to apply it directly to the wound. You would kind of just hang it over. It's a fairly complicated procedure. It takes a while, but with patience, you can draw out the maggots. So then you would obviously want to use tweezers to remove the maggots once they kind of come out from the skin. Once they're drawn towards the blood or the skin of the person where the wound is, and then they, are drawn out, then you can pick them out. You would want to use dry tea bags. So a new tea bag would be best, and then it absorbs. It most likely will get hot or wet because of the drainage from the wound, but then you can change that. How do we clean wounds that are visibly dirty? So you want to irrigate. So we irrigate wounds using a syringe. So usually like a 30 cc syringe, not like a 10 cc syringe. You'll be taking up too much normal saline every time. But what you want to do is you pull the normal saline up into the syringe. You don't have the sharp needle on the end. You can hold a clean cloth or a piece of gauze at the bottom of the wound, and you would want to irrigate it. So you would push the syringe so that the pressure from the syringe would remove any of the dirt from the area. You don't want to scrub. If the person needs debridement, where you would actually cut away slough or non-healing skin, then that would need to be done with the other healthcare team. We often don't do that at the bedside. Irrigation doesn't often lead to bleeding of the wounds. You need to be careful. Of course, you don't put so much pressure on it, but it is the best way to clean a wound. Yeah, lots of questions about maybe next time in this course, we need to have our own nursing session, which would be fun. But I would like to pass it over to Annalice now. We're going to get into our case discussion on the topic is end of life care. So let me just get the presentation. Annalice, are you ready?
Yes, Erin.
Okay, give me 1 minute, sorry. All right, Annalice, you're welcome once you see the...
Yes, good afternoon, good evening, good morning. The case we are presenting about the case on the end of life. This Mr. Ali, 54 years old, has lung cancer with COPD and cachexia. He's seen in his family home within a camp. Within the camp, he is very tired and weak, gradually decline in function status over the past 2 weeks, has been on bed rest for the past week, sleeping for longer periods each day, now only awake for a few hours each day, was managing to drink small amounts yesterday, but today his swallow is weak and he coughs after sips of fluid. He's confused, has confused speech. He's asking to see relatives who have died. A question to be answered, please. What is Alice's prognosis and why do you think this? You can unmute and answer, or you can put in the chat box. Ali, are you speaking? Unmute, please.
Hey, Ali, did you want to share?
I'm going to interfere to answer. Maybe I think with all the signs you gave are signs that the prognosis, the situation is really advanced. So he's really at, like Dr. Hunter said, we are at hours that can be days. He's starting to seeing people, dead people. He's not able to swallow. He has a lot of signs that it's near death. It's like a near death, you know. Question of hours, I think. This is how I.
Thank you. Thank you all. As we have learned from Doctor who has presented on death, end of life, the signs Ali is presenting with are all for hours, maybe, or minutes to death. These are his last days of life. So during Ali's last day of life, which symptoms are we likely to see? Which symptoms may he be experiencing at this particular moment? Looking at what we have learned from Dr. Ali, unmute if you are talking, please.
So a few people, Annalice, have put in the chat dyspnea, so
Okay, thank you.
difficulty breathing or
I've
shortness of
seen
breath,
this.
constipation, pain.
That is correct. We have seen the symptoms in the last days of life are such as pain. The pain now in Ali
Discomfort.
is due to the cancer pain. Difficult in breathing, yes, breathlessness due to lung cancer and the COPD. And then we also have delirium, agitation, common at end of life. And that's why he's having even hallucination. He's seeing people who have already died. Then there is the respiratory secretions, and he's not also taking anything in. Then we also manage such as symptoms when the relatives ask you what they can do, we will reassure them, and then we manage the pain. Pain we manage using the WHO analgesic ladder. That depending on the scale, how the pain is for Ali, we shall use whether we are going to use the paracetamol or brufen and any other that will combat the delirium, or if the pain is mild or moderate or severe, that is how we are going to handle. Erin next. Not following. Yes. Those are the symptoms in the last days of life: pain, breathlessness, delirium, agitation, which are common, and then respiratory secretions, the rattle that the doctor talked about, the rattle stages. Then we can manage them according to the way they appear. Like in Ali has the breathlessness, is hallucinating, that is delirium, the signs of delirium. So we are told that we can manage using pain, we use the whole ladder. Then breathlessness, we can use morphine or oral subcutaneous. It can be either, but we normally use oral or subcutaneous. Oral because we don't want to add more pain to the patient who is already in pain. So we avoid pain injection. So we use oral medications mostly. Then in delirium, we have haloperidol. And then we also have benzodiazepines. These are like diazepam, if mostly people know. Diazepam is Valium in another language. Will calm the patient down, the anxiety will reduce. And then also it can also maybe bring some sleep. The patient is not sleeping. Then respiratory secretions, we can use hyoscine, which it dries up. That is another name is Buscopan. It dries up secretions. Or if the patient, Ali is in home, unfortunately, if he was in the hospital, they can use a sanction machine. We can sanction and remove the secretions. Next. So from here, how do you share with the family that Ali is now dying? How do we share the bad news with the patients and the family? Which steps do we use, class? You can unmute and talk, or you can put in the chat box.
I think we can start telling them about the science, and once we control the science, we can tell them that he is preparing he is leaving now. He might be leaving us at any time, but he is peaceful. So it's important on insisting that he is in a peaceful situation, but he might leave us at any time.
That is correct. Any addition? Yes.
Yeah, thank you very much. First of all, by the time you see that this person or the patient dying, obviously once the dying, you cannot control, because you can inform the family and the people that are going with him. So you tell him that the signs and symptoms of that person before he was okay. At the same time, right now, you may see that the sign and symptom of the death. So you just inform the person, or maybe one of the two person, maybe they with you, and that the person is almost dying. So I personally, I could say so, that one.
Thank you. Anyone
Welcome.
else? Yeah, that is correct. But we're now looking at what we learned before in communicating bad news. There was the model that we used, the spikes. Who can maybe remind us about the spikes? What did we say spikes stand for? You can speak or you can put in the chat. Spikes.
The spike is the way of giving the bad news, breaking bad news, but it's done earlier, no?
Mm-hmm.
Is it? It's how to break the bad news. That's it. The
The
spike.
Yes. Ali,
the spike is when we wanted to handle such patients, the setting. You have to have a good setting for that patient, perception, invitations, and you have to know and do some empathy for the patients. So you wanted to handle or recap the history of the patient.
correct. Yeah, that is correct for Ali and the rest who may be having such a thoughts. Actually, when you are setting up to tell a patient or to pass information about news, or be it negative or positive, you have always to have a setting where you make it comfortable for you as an informer and the person you are giving the message to, because we need to prepare early your information, what you will give the patient. You make sure you have even the appearance, everything you are setting up to give somebody an information. You don't where in a situation that the patient will look at you and will get scared, or also the environment will scare the patient. So we have to get a cool place. We have to make the environment is safe for both the patient and yourself, because when you are giving information, some patient may become hostile and they can harm you. So you make sure the place is safe for you and the patient. And then you prepare the information early. You make sure you go through the results or whatever you want to share, and even the colleagues, you prepare the team, those whom you want to come on board, you make them prepared. And then perception, you have to know, you have to ask the patient what they know about the results and what they want to know, so that you don't give information that is not relevant to them or it is not valid at that particular time. Then invitation, you invite the patient to get to know, like in our case, Ali, the relatives may be worried, Ali is dying, the signs that he's not eating, he's weak, he's not waking from bed. No, you invite them to give you what they want and how they want you to relay everything to them. Then knowledge, you yourself, you have to have the proper knowledge of whatever you want to speak, the language you use, the vocabularies, and everything that in case you are asked a question by the relative of the patient, you'll have to know how to maybe give them information, and who else can give an additional information on what you are giving in the group. That's why we say, like in Ali case, Ali is not feeding. Maybe the nutrition has to be on board, the mental health, because he is delirium, the mental personnel has to be on board, so that each person contributes. The physician because of the pain, and the nurse because of is in bed, he has to take care of the bed pressure, so pressure areas, so that you get the relatives on how to care for they're not turning and everything. Then the emotion of the patient, you have to be empathetic, because when you are giving these relatives this information, maybe you say, I am sorry Ali is getting weak each day. I'm sorry he's going to die very soon. He maybe has some few days or hours left. What do you expect? How will the relatives react to this? You have to be also empathetic in their situation, so that you know how they do it.
Annalice, here's the example of what you could say. We may have to go just finish up now.
Yes.
So Ali is getting weaker each day. I'm so sorry to have to tell you this. Ali is dying. it is likely he has only some days left. And again, we talked quite a bit today how this may be really difficult. So identifying what can you say and how can you talk to them is important. Just some common family concerns. Annalice, do you want to run through this last slide and then we'll finish off?
Yes, yes, please. The common concerns of the family may be because of the weakness and tiredness, lack of oral intake, if Ali can hear them speak, and what we expect, what they expect to do, what they expect next. That's why we are saying that we have to be there. The multidisciplinary team has to be deployed now on the care of Ali. Even though he's at home, we can arrange the team to visit them, or depending on the family, if they wish to bring the patient to the hospital, they bring, so that we can maybe put parental feeding, because if we can't take orally, we can put IV fluids to improve his survival to the end. We can, if he's having things like ascites, they can do the tapping, and then the patient can be relieved of pressure symptoms. Then we keep counseling the relatives and encouraging them until the last day. Then what they expect next, even us as clinicians, we may expect that the patient is likely going to go into coma, and the breathing patterns may change during death imminent time, and there will be periods of apnea when the patient misses to breathe and eventually starts breathing again and finally comes to the resting time. Thank you. Any question, additional, subtraction?
Thank you, Annalice. I think one thing I want to add is I think it's really important to manage the patient's symptoms. There was a few things you added at the end that we don't have time to discuss right now, but I think it's important to talk about. So I'll just share my thoughts and I'll see what Dr. Hunter or one of the other faculties think. But I think when you had mentioned when the patient is lacking fluid intake, we may offer IV fluids to help them till they die. Oftentimes, this is not the best practice to offer that, because patients can't absorb the fluids the same way they could before they were in this end of life period. So if the patient is possibly, the prognosis is not as poor, and maybe you think they're still 3 months, 2 months, and they seem dehydrated, I think it's a very good idea to address that symptom. And I think it's a great idea where you had mentioned to tap someone. So if someone has ascites and is in a lot of pain, I think it's a really good idea to treat that symptom. During end of life, I'm not so particularly sure about tapping ascites at end of life, but I do know we need to be very aware not to recommend IV fluids during this period, to start them. Dr. Hunter, do you have any other thoughts? But I think everything else was really, really a good discussion today.
Yeah, thanks. Great discussion. I agree with that. I really don't offer IV fluids at end of life. I think one thing that's just really important to keep in mind is sometimes patients, or more often families, are worried about the patient being thirsty, and there is no evidence that IV fluids helps people not feel thirsty. What does help is if you keep their mouth moist and their lips moist. It helps more than any kind of IV fluid. So I think that goes back to just the idea of really focusing on what helps the patient to be comfortable right now and reassessing frequently.
And I think definitely if any of you have cared for a person that is during this season, this time in their life or have had a loved one, I think you want to do something. And I think if we can focus on things such as mouth care that would provide comfort, using a cloth, even getting those small little pink toothbrushes, applying moisturizing cream or Vaseline to their mouth, all those things actually, it can take time, and it is something that you can invest your time in doing. And you can really encourage caregivers to do that. If they want to change the person, of course, you don't want to move someone so much, but if their clothes are soiled, definitely, these are things we can do. We can make sure there's, peaceful music, there's candles lit, maybe if they're a favorite book they like to read, reading that, singing. All these things are really important, and we really want to focus on that rather than the more intensive medical treatments that sometimes are recommended. And it's hard, and it will take time to convince and educate your staff members, but I think it is really important. But thank you so much, Annalice. Annalice, you've been a very good new faculty. You've been stepping up and teaching everyone, and I hope that people also will reach out to you. Annalice has been a palliative care nurse for, I think, over 10 years in the refugee camp here in Kenya. So please do reach out to her. We will end our call for today. Thank you so much. I do want to make an announcement. We have our last class next week. Thank you everyone for being so committed. We're going to be talking about self-care. So how do we take care of ourselves when we deal with very difficult cases like this? And often are maybe one or just a few people that are supporting palliative care patients in our area. So please don't forget to miss it. Catch up on your classes that you didn't get, and let me know, email me once you've done that, so we can get you a certificate after next week. And yeah, thank you so much. We are doing a webinar this week for PallCHASE, which is one of our partners that's running this course. So I will just put the information into the chat. If you would like to join us, we'd love to have you. And otherwise, thank you for being here today, and we will see you guys next Tuesday.
Thank you.
Thank you
Bye,
all.
everyone. Thanks, Dr. Hunter. Bye-bye.
Bye. Thank you.
Bye-bye.